Hello, everyone. Welcome to Chapter 8. This one, you'll see that we have 50 slides, but don't let that scare you. There's just a lot to cover in the lower body. If you think about it, we do a lot with our lower body, and we depend upon it every single day. So we're just going to discuss all of the different joints. I'll also discuss some soft tissue, but remember, I want you to take away the big key components here. You're going to hone in on whether it is how it functions structurally or functionally. So please just take a look at that as we go through. Here are the list of all of the joints that we're going to cover today. You'll notice that there's a bunch of joints in the foot. I am not going to make you memorize those or go over these. I'm going to highlight how much there are, but again, I'm not hoping that you take away the joint structures of the foot. That will be another time, another day. But for just reference, as we kind of go through these, we're working from the hips down, okay? From the hips down. First off, we have the sacroiliac joint. This is commonly referred to as the SI joint. This is where the ilium meets the sacrum, okay? So it's this joint space right here. You'll notice that structurally it's fibrous and it's a plain joint. There are a buttload of ligaments, and you can even see them here anteriorly and posteriorly helping to support the structure. Now, sometimes, there's some say that this is not a movable joint, but yes, it does have some movement. It's ampiarthrotic functionally, but remember, you have counternutation and nutation of the sacrum. What does that mean? That basically means that your triangle butt bone, so that triangle middle sacrum bone, we've talked about that with the axial skeleton, that can almost tuck under like a scared dogtail or stick out. So it can nutate and counter-nutate as we move. And so therefore, at that SI joint, we do have movement due to that counter-nutation and nutation, as well as other movements. Now, the big soft tissue thing that we always like to talk about is the sciatic nerve and the piriformis. So if you look here, you have the sciatic notch right here. You should be able to see my cursor. It's pretty big. Well, coming through that big gaping hole is this big nerve, the sciatic nerve. It is the biggest nerve in the body, and it starts up in your butt cheek and ends down in your little toes. Now, it breaks off into other structures, other nerves as it goes down the back of the leg, but we commonly hear piriformis syndrome or sciatica due to inflammation of this nerve and the piriformis. What is the piriformis? It is a inner, so very deep butt cheek muscle that helps to externally and internally rotate the body, or the lower limb. And it can it's called bifurcate. So the sciatic nerve can actually travel through the piriformis, or the sciatic nerve can travel above or below this muscle. And so if we have any irritation, inflammation, or concern with that piriformis, it can actually cause that sciatic nerve pain referral. If you've ever had a literal pain in your butt, that's probably one of the culprits. Now, the pelvis, it is 3 innominate bones that make up one. So each one see these multicolored ilium right here? This innominate bone is the ilium, the ischium, and the pubis that are all fused together, seen right here in the acetabulum, or this space right here, the socket. You have all 3 of these innominate bones joining together, creating one innominate bone, and then you have the same thing on the opposite side of the pelvis. So technically, your pelvis is made up of 6 bones. Isn't that weird? But they do fuse. They are seen as one, the pelvis. And you see a lot of major ligaments around here. One thing that I'm going to point out, and that you'll probably see in your exam, is the inguinal ligament, or Popart's ligament. We never really call it that. I always refer to it as the inguinal ligament, but it spans right here. Most of the time we talk about the inguinal ligament if we're concerned about pregnancy or postpartum pain, or if you're experiencing groin pain maybe you have some sort of protrusion of the guts or the muscles through that space as well, for maybe a groin hernia or something of that nature. Next up, we have the pubic symphysis joint. This is structurally a cartilaginous joint because if you remember, you have that cartilaginous disc that sits between the two pubic bones that are forming together. Seen right here. It's a cartilaginous disc, and then of course we have a buttload of ligaments around there. Functionally, it's amphiarthrotic. It has a non-axial gliding, so it can glide up and down, left to right, wherever. This one I especially treat in my postpartum and pregnant mamas because whenever you do give birth, there's actually a separation at this joint, and sometimes that doesn't heal back appropriately. So sometimes we have to do some troubleshooting. A lot of pregnant women get a lot of pain here, which is always very frustrating. But if you know a pregnant mama, make sure that they aren't just dealing with the pain, because we can help with that. We're going to talk about anatomical differences between a biological male and female pelvis, just because we need to be identifying these whenever we see a skeleton. And you'll need to identify this whenever you are in, say, a medical school or in PT school, AT school, and you have an actual cadaver lab, okay? Number one, the android versus gynoid. This is referring to a person who is assigned male at birth, android, and then person who is assigned female at birth would be the gynoid. This is going to be a triangle for our male and a circle outlet for the female pelvis. Okay. Again, I'm just going to refer to male, female, just for simplistically sake throughout this. You'll notice that the male pelvis has that triangle outlet. Guess what? They're not birthing any babies, so that's how they're structurally intended. And then you have the circle oval, which is perfect for that head to come out. You also see the differences in the narrow versus wider sacroiliac notch. So what's interesting here is if you relate it to what we were just talking about, if you have been experiencing sciatic pain, chances are a gentleman might have some bony articulations that's actually impeding that as well and going to be impacting that. Us as women, we have a little bit of a greater notch, which is wonderful. However, we have a lot more, we are prone to that irritation of those deep muscles. You also have the subpubic arch. Gentlemen usually have a straighter inclination. Ladies usually have more of a curved. We also see a difference in the subpubic arch depending on how their rib cage is. Usually if you have a narrower rib cage just underneath your sternum, you will actually have a narrower pubic arch on a subpubic arch, okay? That doesn't mean that it's not curved. It's just going to be narrower, okay? Dropping down into the hip joint. So the iliofemoral, this guy is it's very busy. We have a lot going on here. So this is your hip joint. It's synovial in structure. It's triaxial ball and socket. So basically it has a buttload of movement. Think about how much you can do with your leg at the hip. You have that acetabular labrum. So if you remember, I said that the socket that the ball fits into is called the acetabulum. Well, around the edge of that socket, you have a labrum. Think of it kind of like almost a suction cup to help keep that head of the femur in there. Now, this can be damaged and injured, but that is the goal of it. You will notice that there are a buttload of ligaments. Again, I will not ask you to memorize all these. However, pay attention to the iliofemoral Y ligament, just because that will be on your exam. Everything else is more for your information. Functionally diarthrotic, because look at how much flexion, extension, abduction, adduction, all the movements we have available to us in this beautiful joint. Now, we've talked about the lumbar sacral rhythm. This is going to kind of take off of this again, the femoral pelvic rhythm as the position of the pelvis in relation to the femur. So with that lumbar sacral rhythm, that was the low back and with the pelvis. Now we have there's a relationship between the pelvis and the lower leg, the femur. Whenever we go into a posterior pelvic tilt, so that means that you tuck your tail under like a scared dog. You're put into more of a position where hip flexion is going to be, excuse me, hip extension is going to be potentially decreased, but you're put into more hip extension and hip flexion is going to have to occur. The anterior pelvic tilt, you will not have, you're almost opening up that outlet where you could go into a lot more hip extension. And then left to right rotation is going to affect the IR and ER femoral rotation. And honestly, I don't care if you know all of these examples. I want you to take away from this that whenever you move your pelvis, it's going to affect how the femur can function and vice versa. Okay, there is a relationship there. Annoyingly enough, everything in the body is amazing. It affects something else. Everything's connected. So keeping these rhythms in mind of the low back, of the pelvis with the femur is very, very important as you continue potentially down the road of an AT, PT, chiro, something like that. You probably, I think I've mentioned these a little bit before, but you have some different angles that are produced with your femur. Okay, and this can be a very good indication of what pathology we might experience or what pathology we are experiencing. Pathology meaning a disorder, dysfunction, or injury, okay? With the femoral head, we have, this is really interesting, at least I think it's interesting. With the femoral angulation, we have something called an angle of inclination. What this means is there's the angle that is formed with the neck of the femur and the shaft of the femur, okay? So like you see here, there's a line drawn through the neck of the femur and the shaft. Now, I know it says normal is 125. That's kind of what we've set as normal. Most people, they're not going to be exactly that number. However, once we start to deviate above and below, this will cause different repercussions and stresses put on the femur and the neck of that femur, okay? Determining this angle, we need an x-ray because none of us have x-ray vision. We got to look on this guy. Now you'll notice that this is like a 90-degree angle, you guys. Here's our pretty 125, and then here's more of a 145, something like that. The different stressors from here to here is going to be different. I'm actually working with a client right now who has this sort of hip, and she has had some disc pathology, or excuse me, has had some hip pathology and is actually going in for surgery in the next couple of weeks. But same thing here. Think about the load and stress that is put on the neck of the femur. If we have a straight 90-degree angle there, that's a lot of potential force that is being placed on that neck of the femur. Again, this is kind of saying what I just said, but also you can kind of match some of these things with how they're going to present structurally and functionally. So they might have more of an anterior pelvic tilt. You might notice that the femurs are more internally rotated at standing and then more pronated. We see this a lot with women or with an individual that set W for a while, and I'll talk about that here in a second. And then the same thing with above 125, okay? Posterior pelvic tilt, we have external rotation, so much more, okay? Now you also have an angle of femoral torsion. We naturally have some rotation up along our femur, okay? So like if I just grabbed my femur at the knee and then at the hip and I just twisted it, we naturally have a little bit of that, okay? At birth, we have around 30 degrees. Normal adult, it kind of starts to straighten out. But we can actually impact that during development on how much less or more we have. And that leads me to this conversation. I always have this conversation every single time. It's kind of my own personal PSA because I see athletes all the time, middle school, high schoolers that have been impacted by their sitting position whenever they were little bitties. So you see here this beautiful young lady, she is sitting in what is called the W position. And if she is constantly sitting in this position, think about what this is affecting, okay? So in at the hips, hopefully you can see my cursor here, we have that internal rotation at the hip socket. But the femur is still like the head of the neck of the femur, the head of the femur is still in the socket. And if she's constantly in this position as the knees are going in together in internal rotation here, it's going to affect the amount of twisting or that angle and how much, because if you think about kids, we always call them like Gumby, right? Like, have you ever seen a 1-year-old or 2-year-old break something? No, because their bones are still a little squishy. Well, as they start to develop into their teens, that bone starts to solidify and harden as they go in through puberty and beyond. That's supposed to happen. However, if we have individuals who are not crawling, who are not learning how to roll over, who are sitting constantly in this W position, it will impact the structure of their bones, which sets them up for further injury and injury risk, okay? So again, that's just my little PSA. If we can get kids out of this position, that would be optimal. Tuck those heels underneath the butt. We would love some good flexion in those knees and learn how to squat appropriately and all that fun stuff. But we want to take them out of this position as much as we can. We can like kind of test this with Craig's test. This is where you have your patient lay face down and then you feel that outer greater trochanter. Remember, that's the huge big knot that's on your hips. It's that bony protuberance, okay? And then we externally rotate until we find that greater trochanter parallel to the table. So basically we're trying to see how much internal rotation we have and how long it takes us to get that externally rotated to where the greater trochanter is parallel to the table. You'd be surprised at how long or how much torsion we're seeing more in kiddos nowadays. So what the fart does this all mean? Like, let's be honest. If you're not even thinking about going into this, this is something that you need to understand just due to the fact that it's going to affect somebody that you love, or maybe it affects you. If we, again, anti-aversion, this is going to be where it's greater than 15. We're going to see toeing in. So like this model right here, where the knees are kind of knock-kneed. It's called squinting patella whenever the knees are coming together, those kneecaps. We're going to have pronation at the subtalar joint. We're going to have internal rotation, and you're going to set yourself up for lateral patellar subluxation. And if you've ever subluxed a kneecap before, it's not fun. Retroversion is going to be like your bow-legged. I always think of like, you know, like a cowboy, like a bow-legged cowboy that kind of waddles back and forth. Your toes are out, your frog-eyed or grasshopper patella. Basically, you know how frog eyes or grasshopper eyes are out towards the side? That's where your patella is going, or your kneecap. You're going to have a higher arch. You're going to have that subtalar supination and then external rotation in the femoral tibia. Okay, so it's always important to note these things. And I usually get the question, especially whenever we're live, hey, is there anything that I can do about this? Yes, there is. Please don't just suffer. There are things that we can do that. Now, if it's too late and you are already formed and all that stuff, now we're just looking at strengthening the opposing muscles to help keep you strong and stable. All right, so tibial femoral joint. This guy is synovial. It's a biaxial modified hinge. What in the world does that mean? That means that your knee joint, yes, you bend and straighten it, right? Well, it actually has some rotational capabilities, okay? That's why it's biaxial. You have some rotational capabilities within that knee. Now, you have these beautiful ligaments that we have all probably heard of in basketball or football game. ACL, PCL, MCL, LCL, these will be on your exam. Be able to identify these or spell these out. But it basically says what it is. Anterior cruciate ligament comes from the anterior to posterior. Posterior goes from posterior to anterior. Lateral is going to be on the inside of the knee, or excuse me, outside of the knee, and medial is going to be on the inside of the knee. Okay, so it basically tells you where it is. And these beautiful structures help with the knee joint, helping it not to have too much of a good thing and help it stay stable. You have two cartilaginous discs Menisci, plural meniscus. You have two of these kind of sitting as ice caps on top of the tibia. You have a medial one that's more C-shaped, lateral one that's more O-shaped. These are not fun to injure. They just kind of can aggravate the whole joint, but they are there, and you've probably heard of that due to somebody that you know or on TV that has had that injured. Functionally diarthrotic, there's a lot of movement there, a lot of flexion, extension, and rotation there. Let's talk about the knee joint and some things that we can see. Remember how I said the bow leg, knock kneed? You have this medial positioning of that tib-fem joint, and that's basically where your knees knock in together. Genu valgum. I remember this because gum, like your knees have gum sticking them together. That's why I remember it. Hopefully that helps you. Valgum, so that means knock kneed. Genu verum, so I think of rum like a drunk cowboy, is more bow-legged. If that helps you, great. And that means that we have that more bow-legged appearance like in this middle picture. Recurvatum. This is a knee hyperextension. We see this a lot in our more bendy individuals, gymnastics, cheer, yoga. I have a little bit of it myself. Maybe you do. Check out your knees, see what happens. This is a fun one to do in person, but we can test for the anterior cruciate ligament by basically bending the knee a little bit, opening up that joint space, and trying to anteriorly translate that tibia. Like I say, it's the anterior cruciate ligament, so it's preventing anterior translation of the tibia. There's several different ways. Lockman's and anterior drawer both help with this. This is not on your exam, but if you're looking to go into this field, you will learn this. The only difference between Lockman and anterior drawer is how much you flex the knee. I always do both because some people are better at cheating the system or tightening down in one position or the other. So I always use these as backups. Medial lateral colligament also has their own tests here. Basically, we try to push into that ligament and see if it gives way. So a valgus stress test means that I'm trying to press that knee inward and see if that MCL helps me out and prevents that. I'm not gonna lie, I do not like the meniscus tear test. As a professional and as somebody who has had knee surgery and knee problems, this one's not super reliable, but I always like to cover it just because it's taught in clinicals and stuff like that. We try to compress the joint and then start to move the lower limb and see if we get any sort of popping, clicking, pain. But I always like to add this asterisk, especially if you're going into this field. There's a lot of stuff going on in the knee joint, and it's a very tight space. So the pain, the clicking that you produce may or may not be the meniscus. It could be things like plica or other ligaments and tissues. So really, we can't know until we go in there or until we have an MRI. Now, does that mean that you need an MRI or knee surgery? No, you can have conservative treatment, but sometimes this test can give us some false positives, which means that it can basically tell us that you tore your meniscus without actually having that. Again, this is how you do it. You're just trying to rotate it around and see what you get. And that's probably why I don't like it very much. So the patellofemoral joint, this one is basically that floating kneecap over the knee joint. It is a sesamoid bone because it's floating, it's tethered together, and it lives in the quadriceps patella tendon. You have some lovely cartilage that is on the posterior side, so between the patella and the knee. That's usually where we get some breakdown. It's called chondromalacia. We'll talk about that here in a little bit. You have major ligaments there, and it's of course diarthrotic because it has a lot of movement. So let's talk about some clinical rotation applications as we're kind of wrapping this up. Maybe you'll see yourself in some of this. I hope that it's helpful for you. So the Q angle, or the quadriceps angle. This is the angle that is created by the center of the shaft. So this line right here, and the path of the quad. So basically the straight up and down. Now females, we naturally have wider pelvises. right? Birthing kids. Again, if you have been assigned female at birth, you're going to naturally have a wider pelvis. And that's not necessarily a bad thing. However, it does open us up for certain injuries. Now, some individuals have a wider Q angle than others. And that's just, again, it gives us kind of some insight into maybe what we might be looking at. We also have the patella. We can look at the patella and it can tell us a lot of things. So some people, yours truly included, have a more medially positioned patella. And this is due to that excessive femoral anteversion. Do you remember what that is? If you don't, go back, check it out. Because we just talked about it, 15 slides ago. Grasshopper, frog-eyed patella. This is where you have that more lateral position of your patella, and this is due to excessive femoral retroversion, okay? So again, how your femur is kind of shaped and which way it goes impacts so much more than just what you would think. Now, this one's interesting. Again, you'll see this on your exam. Patella alta, patella baja, okay? This alta is a more abnormally high patella. Some people, they call it the camel sign, because if you think about like a hump on a camel's back. And then some people have an abnormally low sitting patella. Honestly, I don't see this one as much. Usually I see the patella alta just due to tight quadriceps and the tug that it causes. Maybe this was you. Think about like the tall person in your family, or the tall person that you know. Maybe you are the tall person. Osgood-Schlatter disease happens in our kiddos during that teenage bone like growth and puberty. Okay, you'll see this knot right here. The bone actually grows out of the tibial tuberosity, so it should be like a roughened surface right here, but it starts to form on more bone to respond to an increased force transmitted from the quad muscle. So basically you can wear this sexy strap right here that just holds down the patella tendon and tries to hold it in. Or you can do things like quadricep release, dry needling, exercises, making sure that that quadricep is nice and elastic to help to take off that load from the quadriceps tendon, or excuse me, from the patella tendon. Chondromalacia, I hinted to this earlier. This is the deterioration of the posterior aspect of the patella. Basically, it's breakdown of that cartilage. It happens to almost all of us because we're biped, but especially if you ran a lot, jumped a lot, wrestling, or you have that medial or lateral tracking of your patella, you will probably experience this. This is kind of a cool shot from a surgery, actually. And this is the little tool that they're going to shave off all of this kind of hairy stuff. That's actually the frayed cartilage that has been damaged, and they go in there and they shave all that off. Cool, huh? So I have a fun story with this one. At least I think it's really cool. Patellofemoral syndrome. This is where your patella tracks laterally due to either lateral quad tightness, increased Q angle, anteversion, foot pronation, IT band, patella alta, VMO weakness. You can see that's a whole line. Basically, it could be caused by many different factors. But what it does is it causes irritation and potential subluxations of that kneecap. And sometimes we'll see them put individual in this brace, but honestly, I just want to see you in my office. I want to get everything strong, rebalanced, and teach you how to own your body, because ultimately it's caused by imbalance in the body. So we just kind of got to find out what's weak, find out what's doing too much, and go from there. But why this is a fun conversation is because I had somebody, whenever I was in my first clinical rotation, came in and she had actually hurt herself during a soccer practice. She was crying, and we put her up on the table, and my preceptor, who's pretty well known, he was so much experience. He looked at it and he was like, oh my goodness, okay, so this is, definitely subluxed. And so he goes and he tries to put it back in, puts the patella back in, and it pops right back out. Now, if you've ever had a subluxed patella, it hurts. So now she's crying even more. And so he's like, okay, we need to go get a brace. So he grabs this sturdy thing, wraps it around, and he's like, okay, I'm going to relocate it. He relocates it, it snaps back out. They're like, crap. So they got like 4 of us around there. One of us was holding the patella in the groove. The other people were strapping this thing on. And then we just prayed that it stayed in there whenever we let go. Turns out that person had like an MCL tear, an ACL tear, a PCL tear. I think that part of her quadriceps tendon was torn. She just had a bad day. But it was very interesting because it showed how much this patella counts on the surrounding structures in order to stay where it needs to stay. Sure, you know, we listed all these different things, but once we get into a major injury like that, tell us like, where do I go? What do I do? And you can have that interesting experience that I had on the soccer field. All right, tibial femoral joint, tibial fibular joint. This guy is syndesmotic, fibrous, ampiarthritic because it glides in all the directions, but it's limited. So what does that mean? Basically, you have joints on the top where the tib fib meet, and then at the ankle where the tib fib meet. In between there, you have a fibrous structure that actually helps to keep that together. But these can move, just limited, okay? I'm not gonna make you learn all of these, you're welcome. But in the ankle and the foot, we have a lot of things going on. We have the tail crural joint, which is called the ankle mortis, basically where the tibia, fibula, and the talus meet. Did you know that your ankle is comprised of multiple different bones? It's not just one hunkin' thing. You have something called the talus that sits on the calcaneus, making this beautiful little structure here, okay? Subtalar joint is where this calcaneus meets the talus. Synovial hinge joint has a buttload of major ligaments. We actually want this to be able to rotate a little bit too. And it does a lot of different things for us. We want to make sure that it is nice and happy. Ankle sprains. How many of us have had one of those? We still kind of grade it in grades. It could be just minorly pissed off to completely torn. If you've played soccer or basketball or something like that, you have probably experienced one of these. Treatment for this has changed, so this is the old school. You would quote unquote limit reduce inflammation. You can know my opinion on that. Unless you have completely torn in everything, I'm going to have you moving pretty quickly. I do not want you in a boot. We're going to want to restore that range of motion really, really fast and restore balance and strength as well as endurance. So balance is really, really key with ankle sprains. You would not be like, you would be so shocked at how many of my chronic pain patients, all their stuff started whenever they had a untreated ankle sprain that was like grade 1 or grade 2 that just threw everything off, okay? Mid-tarsal, so basically that means all these little bitty bones that I'm not gonna make you memorize right now have a bunch of plane joint articulations. So that means that they can glide around and should glide around on each other. You have tarsal, metatarsal joints, and then you, of course, have these beautiful ligaments and joints that are created where the tarsals, or these little bitty bones, meet your long metatarsal bones. The one that I want you to know about, I'm going to kind of discontinue everything else, but the one that I do want you to know about is called the Lisfranc joint. This is where the first and second cuneiform meet the first and second ray. So first and second cuneiform meet the first and second ray. This little thing where all of these meet is called the Lisfranc joint. This you will find at the top of your arch. So if you think about your arch as kind of like a pyramid, this would be the top, this would be the apex. And you want that top of your pyramid to be the strongest. So whenever it gets injured, this is where we have a lot of concerns. The Lisfranc ligament is the most commonly sprained with aggressive jumping. Think about a basketball player. We've seen a lot of famous ones recently that have had to actually stop playing or stop their careers due to an injury at this point. Conservative treatment is necessary. It's always confirmed with imaging. but it is a special thing to come back from. I've actually diagnosed a couple of my clients with it, and most of the time it's conservative treatments, it's strengthening the muscles around it, it is making sure that if it's a significant one and we have to have surgery, that we treat it appropriately. And then of course you have where these long rays meet your little guys, tips and pips. These are synovial, axial, biaxial hinge. You have a medial and lateral colligament here. And then it's diarthrotic. Last but not least, here's your pip. Basically where you go up into your little toes. Uniaxial, medial lateral colligament, and then they're diarthrotic. Whew, that was a lot. Hope that you guys hung in there with me. Again, I kind of highlighted some of the stuff that you will see on your exam. You'll see the Liz front joint. You'll definitely see questions about if something's diarthrotic or ampiarthrotic. So make sure that you have your slides on hand for that exam. Hopefully you learned something about yourself or someone you love, and I will see you in your next lecture.